All right, party people, we are back at it with another one. Let's get it. All right, so today we're going to be covering lung pathologies for your licensing exams. So we're going to start off with some idiopathic pulmonary fibrosis, also known as usual interstitial pneumonitis. Now, critically, you have to understand that IPF may appear as UIP on your exams. So you have to be familiar with these terms. Now, when you see a classic idiopathic pulmonary fibrosis vignette, but it's not listed, you are going to be looking for usual interstitial pneumonitis. Now, the classic presentation is you're going to have a patient over 50 years old. The patient's going to have about a 6 to 12 month history of idiopathic dry cough. Now, you're also going to have dry inspiratory crackles heard bilaterally. Alternatively, you're going to maybe see a patient with a 1 month history of a dry cough with an extended history of dyspnea on exertion, and this may mimic left heart failure. As far as your pulmonary function tests, here you're going to have an FEV1/FVC ratio that's increased or normal, but you will see a restrictive pattern. Now, this restriction is due to the stickiness, aka the radial traction, on airway exteriors, which holds the airway open longer than in obstructive disease. Here we have a nice little image showing you exactly what happens in terms of the fibrosis and scarring in your capillary beds and alveoli walls. Regarding buzzwords, if they say reticular or reticulonodular pattern, you're going to think fibrosis. Honeycombing is going to be a little less common and less formal. Interstitial markings on chest x-ray is another buzzword that you need to know. As far as diagnostic sequence, we're starting off with chest x-ray, next high-resolution CT, finally lung biopsy for confirmation. They may ask you about cardiac complications. You need to know that for IPF, this can cause pulmonary hypertension, which presents with a loud P2. This P2 sound is the pulmonic valve slamming shut due to increased distal pressure. You can also see tricuspid regurg. This is heard as a holosystolic murmur, and this holosystolic murmur increases on inspiration. Okay? Now, an important distinction that you need to know is these findings indicate pulmonary hypertension, not necessarily right heart failure. As far as cor pulmonale, aka right heart failure, you have to look for jugular venous distension, peripheral edema, or hepatomegaly. Here we have a nice little image showing the constricted vessels resulting in pulmonary hypertension. When it comes to treatment, we're thinking pirfenidone. This is the answer that they want on your licensing exams. It's an anti-fibrotic agent that inhibits TGF-beta mediated collagen synthesis. All right, next up we have a little COPD, that's chronic obstructive pulmonary disease. So for COPD, we're going to have chronic bronchitis plus emphysema. Now, while COPD is a generic term that can include asthma and bronchiectasis, for testing purposes, COPD equals bronchitis plus emphysema. You need to memorize this. Classic findings that you're going to see are going to be the hyperinflated lungs, which then in turn pushes the heart to the midline. This results in a long, narrow cardiac silhouette or a vertical heart. We have nice little images here showing you exactly what that looks like. You're going to see that the heart is basically being smushed right behind that sternum. The point of maximal impulse is in the substernal midline location. I'm referencing that image on the left as compared to the image on the right, where you have an enlarged cardiac silhouette with lateralization. Here, the point of maximal impulse is in the anterior axillary line. This is presented for comparison's sake so that you understand the difference between COPD presentation via imaging as compared to left ventricular hypertrophy. We've got COPD here on the left and left ventricular hypertrophy here on the right. You need to know normal CO2 ranges. The normal range is from 35 to 45 millimeters of mercury. This will be elevated in a chronic CO2 retainer. The baseline bicarb is going to be 22 to 28. This also will be elevated in a CO2 retainer. pH can be normal or slightly low. This depends on whether the chronic respiratory acidosis is compensated or not. This brings us to COPD exacerbation, and the critical concept here is acute on chronic respiratory acidosis. Here, the CO2 jumps dramatically from a baseline of 50 to about 80. Bicarb remains elevated from chronic compensation, and the pH drops in decompensated acidosis. Now, the high yield point that you need to know is that if you see a COPD patient with low CO2, immediately rule out COPD exacerbation as an answer choice. The second that you see low CO2 in any question, you can immediately rule out COPD from your train of thought. As far as management criteria, here you're going to have patients that are often idiopathic or viral. Now, the key concept to understand is that even if it's viral, they still want you giving antibiotics despite the viral etiology. First-line therapy, you need to be flexible with the drug names, but you have to understand that you're going to be dealing with anti-muscarinic agents such as ipratropium, this is short-acting, or tiotropium as long-acting. You will have beta-2 agonists such as albuterol, which is the short-acting, or olodanterol as ultra-long-acting. Second-line add-on therapy that you can consider is inhaled corticosteroids such as fluticasone. Another important criteria that you need to memorize is the criteria for home oxygen therapy. Here is going to be providing supplemental oxygen when the patient's O2 saturation is less than 88% or a PaO2 of less than 55, or an O2 saturation less than 89% with a PaO2 of less than 60 if cor pulmonale is present. Now, a testing trap that they might hit you with is they give you a patient with oxygen saturation in the low 90s and a PaO2 in the 70s. This does not meet the criteria for home oxygen. You need to know the strict cutoffs. Next up, we got lung cancer screening. Here, you're going to be screening all patients that meet all three criteria. The first being 55 to 80 years old, having a greater than 20-year pack history of smoking, and he has smoked within the past 15 years. And what you're going to do to diagnose this is use a low-dose annual CT. This brings us to chronic bronchitis. The definition that you need to remember is a productive cough for greater than 3 months per year for 2 consecutive years. As far as pathology, you need to know that mucus-producing layer is greater than 50% of the bronchial wall thickness. When I say blue bloater, this is what you're thinking about. Here, you're going to have extensive hypoxic vasoconstriction, which results in cyanosis. And here's an image showing exactly the types of mucus plugging that we're talking about, where you're going to have a comparison between a normal expiratory airflow as compared to the mucus plug that then traps the air. This is the bloating in the alveoli that we were referencing. As far as the mechanism for pulmonary hypertension, step one is you're going to have the mucus plug. This is going to cause the hypoxic vasoconstriction. You then have pulmonary vessel constriction, which results in increased right ventricular afterload. This increased right ventricular afterload equals pulmonary hypertension. This results in chronic pulmonary hypertension and, in turn, cor pulmonale. When I say cor pulmonale, what I want you thinking about is jugular venous distension, peripheral edema, and hepatomegaly. The important distinction that you need to remember is that a loud P2 or a tricuspid regurg alone equals pulmonary hypertension. But a loud P2 / tricuspid regurg plus JVD / edema hepatomegaly, this is cor pulmonale. This is actual right ventricular failure. So the loud P2 or tricuspid regurg alone is not cor pulmonale because that's just pulmonary hypertension. If you have the combo of the P2 / tricuspid regurg with jugular venous distension / edema / hepatomegaly, okay, now we're talking about cor pulmonale. Here I'm going to hit you with a quick side note about acute bronchitis as compared to chronic bronchitis. You have to know that it's typically viral, occurs in non-COPD patients, and presents with a deep, dry cough. But we're not going to get into all this because the scope of this YouTube video / Substack article is lung pathology and not bacterial / viral infections. So let's stay focused and not get lost in the weeds. Next up, we've got emphysema. As far as pathophysiology, here we're going to have the destruction of alveolar surface area, the loss of capillary beds for gas exchange. You're going to have less hypoxic vasoconstriction than chronic bronchitis, and patients are not overly cyanotic. This is to be contrasted with the blue bloaters that were mentioned previously. As far as the pulmonary hypertensive mechanism, we have to be thinking about a parallel circuit from physics, where you have R is equal to 1 over R1 plus 1 over R2 plus 1 over R3 and so forth. Losing capillary beds means removing resistors from that parallel circuit, Therefore, you'll have increased total resistance. This increased total resistance will result in increased right ventricular afterload. This in turn results in pulmonary hypertension and in turn cor pulmonale. Here we have a nice little diagram showing you the circuit. And as far as imaging buzzwords that you need to be aware of, if they say Bulle changes on imaging, this is their way of just telegraphing to you, you have to be thinking about emphysema. Now, the two types of emphysema that you have to be aware of, centra-acinar emphysema and pan-acinar emphysema. Now, centra-acinar emphysema is associated with smoking. Pan-acinar emphysema, aka panlobular emphysema, here the entire acinus is destroyed and is associated with alpha-1 antitrypsin deficiency. You need to memorize this. So let's hop into alpha-1 antitrypsin deficiency. The key facts that you have to remember is that the inheritance is codominant. The worst genotype is ZZ. They will test you on this. It's important to know that alpha-1 antitrypsin, normally produced in the liver, travels to the lungs and breaks down elastase. A deficiency in alpha-1 antitrypsin results in increased elastase, which results in emphysema. Now, the classic presentation that you will see is a 20-something never smoker with Bulle and emphysema. The trap that they might set for you is give you a 30-something with only 3 years of smoking history plus emphysema. The patient's father died of alcoholic cirrhosis. The point of this type of question is that you have to know that alpha-1 antitrypsin deficiency causes accelerated emphysema and cirrhosis. So a 33-year-old shouldn't have emphysema from just 3 years of smoking. For that type of presentation, you'd expect a 60-year-old with 40-pack year history of smoking and then subsequent emphysema. Next up, we've got asthma. So the pathophysiology here is bronchospasm due to idiopathic, hereditary, or antigenic triggers. In a typical presentation, you have to know this, that about a third of patients will have cough, air, and asthma. Here you'll have a patient present with dry cough only. This is especially worse in cold air, think winter, and no shortness of breath, as well as chest x-rays will show mild hyperinflation or can even be normal. So a classic scenario will be a 10-year-old with unexplained dry cough. The atopic triad that you need to know, this is the classic constellation. Dry cough in winter, rhinoconjunctivitis in the spring, and eczema in the summer. As far as fun facts that you have to remember for the exam is that on these, you almost always have asthma presenting in winter. Very rarely will they give you a dry cough in the summer. Here we've got a nice little image of the triad to kind of visualize and help you remember. This brings us to aspirin exacerbated respiratory disease. The mechanism that you have to remember is the leukotriene pathway. So here, you're going to have the arachidonic acid and the COX pathway, which is the prostaglandins or the lipooxygenase pathway for leukotrienes. The leukotrienes that you have to be aware of is C4, D4, and E4. These cause the bronchoconstriction, and leukotriene B4 is a neutrophil chemotactin. This is unrelated, but it may be tested. When aspirin or NSAIDs block COX, arachidonic acid is shunted to the lipooxygenase pathway. Therefore, you'll have increased leukotriene production, which in turn results in bronchoconstriction. Now, the classic thing they'll show you is a teenage football player who takes aspirin for muscle pain and all of a sudden has shortness of breath. In this case, you do not use ibuprofen or naproxen because it's the same as aspirin. Instead, you will use acetaminophen. This is a central COX inhibitor. Now, what you have to remember is Samter's triad. This is aspirin sensitivity, nasal polyps, and severe asthma. This triad does show up all over your licensing exams. Here we have a nice image showing you the arachidonic pathways with the NSAIDs blocking cyclooxygenase on the left, and we have LOX on the right, as well as the subsequent leukotrienes, and as well as the prostaglandins. All right, let's get into blood gas analysis for acute asthma. The initial presentation is type 1 respiratory failure. Therefore, you will have CO2, which is low. The pH is high due to the CO2 being low. The bicarb is no change because the kidneys haven't had time to compensate, as well as O2 being low. Now, you might be asking, why is CO2 low? The answer is because the alveolar surface area is intact in asthma. CO2 diffuses 20 times faster than oxygen. So despite bronchoconstriction, hyperventilation allows CO2 to escape rapidly. And when you hyperventilate, you're blowing off all that CO2. Therefore, it'll be low. Now, type 2 respiratory failure is impending. So the danger sign for this is a normalized CO2 while the O2 remains low. This means the patient is now tired. The respiratory rate is decreasing and that CO2 is accumulating. Therefore, you'll need intubation before the CO2 gets so high that it causes respiratory arrest. You have to be able to compare and contrast this with COPD. In COPD patients, they are chronic CO2 retainers with destroyed alveolar surface areas. Therefore, even with a respiratory rate of 30, their CO2 might be 80 millimeters of mercury because that gas cannot diffuse due to the damaged surface area. The universal rule, except for COPD, is elevated respiratory rate equals a low CO2. Here we have a little diagram going over the blood gas results for asthma, whether it be mild, moderate, or severe. Notice that the pH goes from increased to decreased depending on whether that CO2 is blown off or retained, moving from mild to severe. As far as spirometry, the classic finding is you will have the scooped out loop or the concave expiratory curve. This is an obstructive pattern. You'll have the increased expiratory phase. This is a buzzword for obstructive lung disease, especially tested in asthma. As far as asthma diagnostics, we have the methacholine challenge. This is a muscarinic receptor agonist. It reproduces asthma symptoms. You never give this during an acute attack. And this is used in outpatient between attacks to confirm a diagnosis. Let's get into the stepwise approach to management for an acute asthma attack. We're going to go ABC. The A is for air, oxygen is always number one. B is for beta-2 agonist. We're thinking albuterol inhaler or nebulized. C is for corticosteroids. We're thinking IV methylprednisolone. The key point that you have to remember is that inhaled corticosteroids have no role in an acute attack. As far as chronic management, the steps include step 1, beta-2 agonist, PRN. We're talking about albuterol. Step 2, you can add an inhaled corticosteroid. Think fluticasone. The indication is weekly or biweekly episodes despite albuterol. Next, step 3, we increase the inhaled corticosteroid dose. Step 4 is we can add a long-acting beta-2 agonist such as salmeterol or formoterol. Step 5 is we can try additional agents before oral steroids. We're thinking cromolyn sodium mast cell stabilizers, xylutnon, lipoxygenase inhibitors, montelukast, zafirlukast, which are leukotriene receptor antagonists. Finally, step 6, here we have oral prednisone. This is the last resort. This is the most effective for preventing episodes. This is to be avoided due to Cushing syndrome risk, as well as impeding linear growth in children. Here are some special prescribing rules if you're dealing with a hospitalized patient. The patient must receive inhaled corticosteroids even if it's newly diagnosed. What they might do to trip you up is give you answer choices like fluticasone plus albuterol with fluticasone first. This is correct. Both can be co-initiated for moderate asthma. This brings us to bronchiectasis. Here, we're going to have the dilation of airways. This is from the Greek ektasis, which means dilation. This can be described as a loss of musculature of the airway. Now, in terms of worldwide, TB is the most common. In Western countries, we're thinking cystic fibrosis, and from general causes, we're thinking smoking. It's important to note that asthma does not cause bronchiectasis, even if it's very severe. Here we have a nice little CT scan showing you the tram track appearance that is often seen. Now, the classic presentation for about 90% of cases is you will have copious amounts of foul-smelling sputum. Now, this is context-specific. If we have a smoker, a patient with TB, a cystic fibrosis patient with copious amounts of foul-smelling sputum, then we're thinking bronchiectasis. However, if we have an alcoholic with foul-smelling sputum, we're thinking aspiration pneumonia or lung abscess. Therefore, foul smelling should be associated with anaerobic bacteria such as bacteroids. As far as atypical presentation, you might have a right middle lobe syndrome where you have a young child, scanty white mucus, dry cough, and linear opacity in the right middle lobe on imaging. The associated finding is the clubbing of fingers, and this is also seen in smoking, cystic fibrosis, but the common buzzword in a bronchiectasis vignette. So you have to know that clubbing of the fingers needs to point you in that direction. Next up, we've got atelectasis. The definition means lung collapse. This is clinically significant because it's the most common cause of fever in the first 24 hours after surgery. They might try to trip you up by giving you a fever 2 days post-cesarean section. You still have to consider atelectasis highly on your differential for early post-op fever. Now, as far as post-op fever differential, before we jump to sepsis, UTI, thrombophlebitis, drug allergy, or abscess, we have to first consider atelectasis. The sequence that you have to connect is pain medications with decreased mobility, as well as shallow breathing. Here, we'll have opioids such as oxycodone or hydrocodone, which slow respiratory rate. The patient's not taking deep breaths, and the lung collapses eventually. On imaging, you will see basilar opacities or basilar shadows. Other causes that you have to be aware of is obstructive/resorptive atelectasis, such as tumor-causing obstruction, post-obstructive pneumonia. Next up, we've got obstructive sleep apnea. The blood gas pattern that you will see is a chronic CO2 retainer. This is similar to COPD. Therefore, you'll have high CO2, high bicarb due to compensation, as well as a normal or low pH, and this depends on the level of compensation. Now, the major complication is cor pulmonale. You'll have an obese patient with a polysomnography showing 15 to 70 awakenings per night. ECG will show right axis deviation, and you'll have signs of right heart failure. Remember, jugular venous distension, as well as peripheral edema. Here we've got a nice image showing that the normal blood vessel as compared to pulmonary hypertension. The mechanistic pathway that you have to remember is that recurrent apnea results in hypoxemia. The hypoxemia results in hypoxic vasoconstriction. This vasoconstriction results in pulmonary hypertension, and in turn will result in right ventricular hypertrophy, which leads to cor pulmonale. Now, the signs of right ventricular hypertrophy is that you might see right bundle branch block. You'll have a right axis deviation, as well as a wide splitting of S2. This is specific for right ventricular hypertrophy, not just pulmonary hypertension. It's best heard at the left sternal border in the pulmonic area. Now, an important distinction is loud P2 alone versus wide splitting of S2. If they give you loud P2 alone, this is pulmonary hypertension. If they give you a wide splitting S2, this is right ventricular structural changes, which is indicative of cor pulmonale. You also have to make the association of obstructive sleep apnea with mood disorders due to the medical condition. This is similar to hypothyroidism. And the way to diagnose this is polysomnography, aka a sleep study. Next up, we've got anaphylaxis. So this is type 1 hypersensitivity. Here we have an antigen such as pollen, bee sting, peanut. They can all bind to the IgE on mast cells and basophils. This causes a cross-linking, which results in degranulation. Here the release of histamine and prostaglandins occurs, and therefore this results in eosinophil recruitment. Here we've got a nice little image of a mast cell degranulation taking place. A lot of times they'll show you an image where it almost looks like the mast cell is getting cracked open due to all the receptors being pulled to one side. That's at least how I like to remember this. But here, when you see the histamine, cytokines, prostaglandins, tryptase being released, this image should help you remember the sequence that takes place. If I ask you what is responsible for the presentation of this patient's condition, your answer is histamine. If I was to ask you how do you treat this condition, your answer would be epinephrine. Now, as far as hemodynamics, in distributive shock, the vascular resistance is decreased because your vessels are dilated. Your cardiac output is increased because your heart's pumping harder trying to fill those dilated vessels. Pulmonary capillary wedge pressure is normal, or it can be decreased in some cases. You have to remember that cardiac output is high in anaphylaxis, not low. Now, the treatment is intramuscular epinephrine. This is due to the alpha-1 agonism, which constricts arterioles. This restores blood pressure. Also, the beta-2 agonism, which opens up your airways. This relieves the bronchoconstriction. As far as preventative immunotherapy, they might ask you, in addition to epinephrine, which of the following decreases recurrence? And the answer is venom immunotherapy. It's important to note that venom immunotherapy is a generic term used on your exams just to reference antigen desensitization, not just bee stings. Don't overthink it, click it, and move on. As far as scombroid poisoning, the mechanism occurs with meaty fish such as mahi-mahi, mackerel, or tuna. The bacteria produce histidine decarboxylase. This converts histidine, which is an amino acid, into histamine. The result is anaphylaxis-like presentation. Here, you'll have a patient who has eaten fish before without issue, travels somewhere like Indonesia, eats mahi-mahi, then all of a sudden develops asthma-like symptoms. This is not fish allergy. You have to understand that scombroid is from meaty fish only, not shellfish. So if a vignette gives you shrimp, crab, lobster, this is in fact shellfish, not scombroid. Now, just because they put scombroid higher up in the list, it might come up before shellfish allergy. So you have to read through all question choices before you click and make your choice. So some key takeaways, let's spin the block. Know the buzzwords: UIP, reticular pattern, honeycombing, vertical heart, foul-smelling sputum. Understand the blood gas levels, whether it be low CO2 in asthma and pulmonary embolism, high CO2 in COPD, and obstructive sleep apnea. You have to recognize atypical presentations such as cough variant asthma or right middle lobe syndrome. You have to be able to distinguish pulmonary hypertension from cor pulmonale. Think loud P2 versus loud P2 plus jugular venous distension, as well as edema. Now you have to master the stepwise approach. This is asthma management. This is heavily tested. And do not jump to rare conditions. So in the example of scombroid poisoning for meaty fish, don't forget that if they give you shellfish, that's shellfish allergy. All right, that's going to be it for this one. If you like the video, comment, share, subscribe, and check out my Substack, where I post written versions of these questions and a lot of these walkthroughs. Feel free to leave comments as to what you'd like to see from me next, and I'll catch you in the next one. Go crush it.